So we don't want to see these kind of late presentations and chronic lateral condyle fractures. So the aim of this talk is to prevent these kind of late presentations, these kind of scenarios presenting in our outpatient. Okay. So it's very obvious that we have a lateral condyle fracture here. So anybody, even in half awake, they can pick up a fracture here. But it is important to pick up these very subtle injuries. Okay, it looks very sweet and innocent, but it's actually not. So if you look at the dissected specimen here and compare with the radiograph on the left side, you can see a small flake of metaphysis in the X-ray, whereas actually it's a big chunk of chondrosseous part of the distal humerus. Okay, so the correct treatment starts with correct assessment. Okay, the first thing what you need to do is look at the soft tissue swelling and look if the child allows, you look for any instability here. So a lot of soft tissue swelling like we saw in the morning, that indicates a significant disruption of the periosteum and the soft tissue. It indicates an unstable fracture configuration. So next comes assessment of the fracture anatomy and its stability. Okay. So you can look here, this X-ray looks relatively normal here. So this is an AP view, what we think is an undisplaced fracture. If we rotate the limb internally by 15 degrees and take an X-ray, you can see there's a fracture here. So it's essential to get an internal oblique view whenever you suspect a lateral condyle fracture. So this is another X-ray, same child. The staging of this, actually these fractures differ when you compare with an AP and lateral views. So internal oblique view shows a stage 4 fracture. So this was described by Song et al. And he said that 70% of fractures, the amount of fracture is higher and the staging also is higher if we take an internal oblique view compared to an AP view. So essential radiographic examination of suspected lateral condyle fracture has to be all three views, AP lateral and 15-degree internal oblique view. So coming to the stability. So Song has described this staging of fracture which has 5 staging, whether the fracture is displaced less than 2 mm or more than 2 mm. So based on that, he has 5 stages. The first 2 stages is defined as sort of a stable fracture where you can observe or do a weekly follow-up and then treat. The 3rd, 4th and 5th stages are unstable fracture configurations. So it is sometimes very difficult to assess these staging on an X-ray. So I feel whenever you have a doubt, so these are a diagrammatic description of how these stages progresses. So whenever you have a doubt, don't hesitate to get an additional investigation, especially an MRI is which can be done, or an arthrogram when the child is under anesthesia, you can get an arthrogram. Okay. So look at this X-ray on day 1 and this is an X-ray on day 5. So what has happened? The fracture has displaced. This is what we call as late displacement. Okay. So why does this happen? This something looks like our humble politicians which are very simple and look sweet when they present initially. After the elections they look different. Okay. So if you remember this, do not forget that there can happen a late displacement in lateral condyle fractures. Okay, so why this happens is because the cartilaginous hinge which is holding the fracture fragment, the cartilaginous fragment initially, and this is pulled by the common flexor, the common extensor origin, and the cartilage breaks and the fracture starts to displace. So however, one thing you need to remember that there will not be complete displacement and rotation of these initially little displaced fractures, but they sort of translate and it can go on for delayed union or malunion. So this late displacement, as I said, when you look at the dissected specimens, there is break in the cartilaginous hinge and it can go on to disrupt. So if you remember this slide, you will never forget how to treat a lateral condyle fracture, what is the pathology of late displacement. So the risk factors are significant soft tissue swelling which is present initially, which signifies a lot of soft tissue injury, then gap at the fracture site laterally, then the fracture line is through the epiphysis, that is type 1 Milch, and if the initial displacement itself is high. Okay. So intraop you can get a varus stress view and test the stability. So this we did in the morning and we found that the fracture was unstable with varus stress. So if you look, how do you treat these fractures? The relatively undisplaced fractures, Song 1 and 2 stage, there is no soft tissue swelling. We follow protocol of putting a slab or a cast, long arm cast, and follow up them every week. You have to counsel the parents that these fractures can get displaced anytime, so you have to come without fail at every week interval. And when they come for follow up, we have to take off this splint and then take the exercise in all 3 views and look for any fresh displacement. So if there is no displacement, you can treat for the cast for 3 or 4 weeks, depends on the child, the age of the child, and then start mobilize. If it's a displaced fracture, most of these fractures can be treated with a close reduction and thinning. So if the displacement is more initially, so you can do a close reduction and thinning. If it fails, then always be prepared for an open reduction. So if it's a gross displacement, there have been papers where stage 5 also have been reduced by closed means and thinning has been done. So you can try always close reduction, but if it doesn't come, you can try we have to go for open reduction. So we did this morning, do an arthrogram assisted fracture fixation. So it's a very simple technique, adds little to the cost and time of the surgery, but it helps you in a good reduction. Okay. So indications for open reduction, as I said, if you're not able to achieve a good articular reduction by closed means. So what I want to remember is it's an interarticular fracture. Aim for a perfect articular reduction. Blood supply is precarious. When you try for open reduction, preserve the soft tissues.